Well, let's go ahead and get started. Thanks to Dr. Cohen as course director for doing some moderation and watching for questions. Really appreciate her. This is a talented group of people that are here today, so I really appreciate it and looking forward to some discussions. And so this was a topic that I thought a lot about, and it comes up so many times with my work with my good colleagues over at the Integrated Memory Care program. And the title of this talk is Mom is Acting Funny, Can We Check Her Urine? And so I want to walk you through several different things about this topic. And we've got some audience participation as well. So looking forward to that. I have no disclosures relevant to this presentation. So thanks so much. So we do some poll everywhere. And so there are several different ways that you can participate in poll everywhere. If you have this app on a computer or on your phone, you can go to pollev.com and use my name, Baldhead Ted. You could scan this QR code. And so let's go ahead and start with the first one. So I want you to type in a medical symptom, any medical symptom that you want. It'll make more sense after we do this for a second. And so I'm just making sure that poll everywhere is working. And you should have the opportunity to enter a medical symptom there. Any medical symptom. Waiting for your responses. Okay, we've got one. We've got headache, fever, fatigue, dizziness, nausea, sneezing, headache, confusion. I'll give you just a second to add some more. All right. So headache seems to be the top one. We're going to go on to the next one. I'll just take a quick picture of this so I can remember. All right, great. And here's your next question. Type in a length of time, a length of time. Okay, I've got it. And here's your next one. Properties of a liquid. Okay, got them. And last one. A human state of being. Okay, got it. Hey, thanks so much. So if you're not familiar with Mad Libs, we'll reveal in just a second. And so here are the learning objectives for today. Understand caregivers' perspectives on urinary tract infections and changes in what's going on with them. Examine the evidence for asymptomatic bacteriuria as a cause for delirium and ADRD, Alzheimer's, dementia, and related disorders. Hey, give me 1 second.
I just want to say hello.
Hello, it's great to see you.
You're the chair of
Hold on for just 1 second, folks. Sorry about that. When the dean comes by, you do say hello. And examine the evidence for asymptomatic bacteriuria and Alzheimer's disease and related dementias. Examine the evidence for UTI as a cause of delirium. and evaluate prevention and non-antibiotic approaches. And so when I was talking to folks in our clinic about, all right, so can you give me a case? And it was like, it's kind of like Mad Libs. It can be it can be anything coming on at once. And so here were your most popular answers. My mother has headache symptoms that started 3 days ago. I noticed that her urine was wet. She might have a UTI again as she got happy with antibiotic treatment. That's not so bad. You could say, my mother has nausea. It started 3 weeks ago. She might have a UTI again. I noticed that her urine was dark. She might have a UTI again as she got grateful with antibiotics. And so let's go into this just a little bit deeper. Here's a case, a real case, not a Mad Libs case. 74-year-old female diagnosed with Alzheimer's disease. And I'm going to take you up to the present in 2023, but I wanted to give you some information about her 2020 baseline. She has a dementia severity rating scale of 33, which is moderate towards the severe side. She doesn't know what day of the week it is. She is not sure whether she had her last meal, what it was, or when her next meal would be. The answers to questions are hard to understand or nonsensical. And she, for the most part, is continent. She can't do her own cleaning after toileting, but she does not have regular bladder accidents. Her ADL score is 8 out of 51, with lower being worse. She does not feed herself. She requires major assistance in dressing. And as mentioned before, can't clean herself thoroughly after toileting. And she has no, there's a missing D there. She has no IADL activities, those instrumental activities of daily living. She doesn't do any transportation, any meal prep, any finances, or anything like that. She is distressed by severe hallucinations, and she overall has poor appetite and little eating or drinking. And so we got a portal message from the husband, who's the caregiver in this case, and said that she's sleepier and less interactive. And I recognize that we're changing medications to try and deal with this, but can we check her urine? And so the good folks over at Integrated Memory Care Clinic responded to this very timely. And we did get a urinalysis. And so notably on the urinalysis, the urine was hazy. The specific gravity was 1.028. If you remember your maximum renal concentrating ability, the maximum specific gravity is 1.030. So this is a very concentrated urine. There are no nitrites, and there are just trace leukocyte esterase. If you look back over time, 2 years ago, she also had large leukocyte esterase. She had a very concentrated urine, and 3 years ago, she also had moderate leukocyte esterase and negative nitrites as well, but also a very concentrated urine. So consistent with what we've known about this patient for the last 3 years, she does not drink a lot and is likely dehydrated for most of the time. So we did check this urine, and we sent this urinalysis off, and we got this output from the urine culture. 2 organisms greater than 100,000 colony forming units of Klebsiella pneumonia and Enterococcus fecum. And so we did offer treatment. And then 1 month later, a follow-up culture showed that a different Klebsiella subspecies, some new resistance to cefazolin, and the E. faecium is about the same. No new problems there. Some of the folks on the call take care of this individual, and so welcome their comments in the chat in terms of whether or not she got better from the antibiotic treatment. But we don't believe that there is a major change in response to antibiotics. And so I'm going to give you another opportunity to pipe in. I wanted to think about what caregivers' perspective on urinary tract infections and changes that happen in their care recipient. And so here's the QR code again. If you joined a little bit late, you can scan, you could do pollev.com, baldhead Ted. And what do you think about caregivers and their feelings about searching for urinary tract infections? Do you think it's important to them? Do you think that they are very interested to find out if their care recipient has a UTI? Do you think that this is something that they're not concerned about. So let's see what responses you have. So go ahead and type a clip of a phrase or some information in there. If you're having problems with poll everywhere, I'll go ahead and read some chats as well. I see one chat response. It's often the easiest answer when there's a change in behavior. They're eager to find a problem that they feel that they can solve. They're curious to know what's happening. Other responses. What's your experience of caregivers and their inquiry about, is there a urinary tract infection? We'll give you just a second. They're concerned about sepsis. Really good point. They've heard of or they've had somebody go into the hospital before with a urinary tract infection and a sepsis syndrome, and so they're worried about that. They're anxious when there's been a positive urinary tract infection. Other aging professionals have suggested this as the most likely cause. Well, let's talk about some of the things that aging professionals say. And so there are a lot of messages in the lay press. And so I just did a search and found about 12 of the top 15 answers. Treatment for UTI may lessen confusion, unlocking the causes. If women are getting UTIs, that causes them problems. Delirium may be precipitated by a UTI. They might be suffering from delirium brought on by a urinary tract infection. Yes, UTI can trigger behavioral changes in delirium. And so the answers that you get in the lay press are very clear and to the point. Yes, this is a thing. I am on a reading challenge this year. In 2023, I want to read 40 books. And so I wanted to just tell you about book number 37 and book number 38. And so here's this first book. Elizabeth Ekstrom is a really smart geriatrician out at Oregon Health Sciences University. She does a lot of work on fall prevention. She also does some work in ADRD care. And Marcy Cottrell-Houle is an author whose career was nearly practically derailed from the caregiving that she provided to her father, who had Alzheimer's type dementia, and her mother, who had a stroke. And so it was an interesting back and forth. This is a book from 2015. They have a new book out in 2023, in case you're interested in following these authors. And so I thought that Marcy, as she calls herself in the book, had 5 things that she frequently talked about with regards to caregiving. One is it was a very hard job. 2 is that she had to advocate to make things happen, or even good things happen. She had to be present and advocating. She felt, Elizabeth Ekstrom felt that it's really important to communicate what a patient's baseline is. Marcy felt that providers don't really know the difference between delirium and dementia, particularly the hospitalists that she ran into. And her 5th and final message was find and treat urinary tract infections. And so there is multiple passages in the book that were speaking to kind of what it was that you could do if you found a UTI and treat it. And so there's a lot of messages out there. This is my 38th book that I'm reading right now. You might wonder what a shipwreck book has to do with what's going on. But early in the book, it was clear that people who were put onto ships and boats for the British Navy or for merchant marines were often kidnapped and captured and taken out of the poorhouse or wherever they were and put on a boat against their will. That kind of resonates what some of the caregiver experience was. They didn't sign up for this necessarily. They might not have the skills and requisite ability to do this. And I think that this UTI and delirium thing is we all impose some coherence or some meaning on the chaotic events of our existence. And so one of the comments in the chat is that, this is something that they can find and control. So let's look at some of the evidence, and maybe the caregivers have this right. Maybe we have it wrong. Maybe we have it right. Maybe the caregivers have it wrong. So Lindsay Nicole is just a rock star of an ID specialist, and you can find her 2019 update of asymptomatic bacteria, just a definition here. 1 or more species, 10,000 colony, 100,000 colony forming units. You don't have to have pyuria, or you could have pyuria. It's still asymptomatic bacteria. No signs or symptoms attributed to the urinary tract infection. So here's some of the statements within this, and that is that and then the 2019 as opposed to the 2005 guidelines, they really address people with Alzheimer's disease and with delirium. And so I really thought that this was good. They found that in patients with functional or cognitive impairment, bacteria and delirium without local GU symptoms or other signs of infection, i.e. fever or hemodynamic instability, recommend assessment for other causes and careful observation. And that's a strong recommendation, but very low quality evidence. And some other ones, observational changes, evidence suggests that patients with delirium are more likely to have bacteria than others, but this is correlation and not cause and effect. And one final thing from Lindsay and the group is that if you are sending somebody to the hospital, if they do have signs consistent with a severe infection and without a localizing source, you use broad spectrum antimicrobial therapy. Came up today in terms of one of our patients who had been sent to the hospital with a presumed diagnosis of urinary tract infection and sepsis. The initial treatment was specifically targeted to urinary tract, but very quickly the team broadened their antibiotic coverage. And if you looked at some of the presenting things that were going on with the patient, there is actually hypotension and confusion and hypoxia and some other things that maybe they fit, maybe they don't. Severe renal insufficiency, very consistent with severe dehydration. And so again, the message from Lindsay Nicole and her team is broaden your differential, don't prematurely have diagnostic closure as to what the cause is. So let's examine the evidence for UTI as a cause of delirium and ADRD. We were just talking about asymptomatic bacteria. There's something that's called the McGreer criteria, and there's something that's called the Loeb criteria. The distinction between the two is the McGreer criteria is really kind of an audit tool for what you did. And the Loeb criteria is actually a looking forward to figure out should you administer antibiotics or not. So here's the problem, thinking about our patient who doesn't know how to answer questions. The lead in to diagnosing a UTI is a report of dysuria. And if that isn't there, then you go down this other pathway. It's a temperature, and not all of our older patients have elevated temperature. And so they do say 1.5 degrees Celsius above the baseline. And then either some symptoms or signs, urgency frequency, very common in folks, and then some suprapubic pain, gross hematuria, CVA tenderness, and urinary incontinence. I don't believe that we're asking our caregivers to do some of these things when they're at home, pound a little bit on the back. Is there blood in the urine? Is there pain suprapubically? And so one of the things that it does say about urinary tract infection, and this came up the other day in clinic, is you have 3 or more species within the culture. That suggests that these polymicrobial are possibly contaminant, and we wonder that from our patient as well, who has really poor hygiene. I don't know exactly how they got a urine for sample. So here's an interesting thing. A lot of the early systemic reviews of this topic about UTIs and deliriums, they basically threw out all of the literature because there were not objective criteria for UTI and delirium. And it's like, how can you figure out with the associations if you don't have standard definitions? And then this Krenitsky article was a recent one in the Journal of the American Geriatric Society. It suggested that across multiple studies, there is a relationship between delirium and UTI. But here's one of the caveats versus the other articles where they threw out the literature that didn't fully diagnose a UTI. They allowed in this review the ability of a coding of urinary tract infection. So all of the previous articles that were negative because we can't review the literature, now they said if there's even a code that diagnoses a UTI, then we'll count a coding of UTI and delirium as showing an association. So this is strong in terms of the odds ratio. And so there's probably something to this, but the data that we have is just not so great. So I'm going to end with just evaluating prevention and other non-antibiotic approaches. And I'm going to end quickly so that we can back up into the room and have some conversation about it. I like this from the Advances in Emergency Nursing Journal that was talking about, don't prematurely anchor in on this as a urinary tract infection. And they have an A, B, C, D, E, F of things to think about. Thinking about the bladder, A catheter indwelling or urinary retention are also things that can precipitate delirium. So it's not just a urinary tract infection if you're thinking about the bladder. Pharmacy doesn't start with an F, but it does in this algorithm. Thinking about medications that are there, pain, constipation, and other things. So I thought that this was a kind of a useful way to think about it. So I'm gonna not show you this end survey just yet because we're not done, but I'll come back to that. And just want to hear kind of from smart folks in the room. What do you think about this topic? Do you think that we're underdiagnosing? Do you think that we're overdiagnosing? Do you think that the caregivers should be kind of re-educated about this whole UTI and delirium thing? Or do you think they're right and maybe science is wrong? What do you have for me? Feel free to come off of mute and offer some perspectives.
It's definitely such an interesting topic, Ted. I agree. And it happens so many times in clinical practice, and you really don't know what to do. Of course, it's easier to prescribe antibiotics than not to prescribe, just to be covered. But then you see this resistance, and then these patients, usually women with poor hygiene, they have one ITU after the other, and it's really hard to see where they have symptoms or not. So it's definitely a problem we face on an everyday basis. And sometimes we don't really know what to do. So it's nice to have the information and to know that the threshold for antibiotics, sometimes we could be a little more strict and not prescribe so easily. So I think it's a great discussion.
Thanks so much. And we've had some patients that we've put on chronic antibiotics. We have some patients that we've used medications to sterilize the urine. If Debbie will remind me of the name that's just slipped me. It's the one that converts into formaldehyde in the urine.
Hiprex.
Go ahead, Allison.
Isn't it Hiprex? Methenamine.
Yeah, methenamine. There we go. And so we've done that sometimes, and in certain patients, a lot of patients are getting these urine test strips at home. They're testing at home and they're given a positive result and saying, call something in. Sometimes it's better to have patients with antibiotics at home that they can start at the earliest signs and symptoms. I don't know that we're getting a lot of reports on does your care recipient have a fever? I don't think that we're getting
patients that were colonized with E. coli, one infection after the other, and the combination of D. mannose with cranberry was very effective. Apparently, D. mannose is what the bacteria, the E. coli, used to get attached to the bladder, to the mucosal bladder. So if you prescribe just this over-the-counter D. mannose with cranberry, it really helps. At least in a few patients, I was able to decolonize and decrease the rate of antibiotic prescription a lot. So that's also very useful.
In one of my older patients, we were able to use a vaginal estrogen cream. There's a window for somebody being able to do that. And that actually was favorable in reducing a recurrence of urinary tract infections and certainly bacteriuria. Other smart people on this call who want to offer some perspectives.
So we have in the chat, there's 8 in 10 cases, there is no fever. Yeah, of course. Yeah. Thank you for the comment.
Ted, I may have missed it, but I also like to begin the protocol with increasing oral hydration. And I understood that's early CDC guidance for urinary symptoms, including, I think, some systemic symptoms, not fever, obviously, or pyuria.
I think that that's really prudent advice. And one of our good friends, Namali Stone, who was the author of the updated McGreer criteria in long-term care, actually had a hydration protocol as the first step. And that's a great cycle for people whose complaint is the urine's dark, the urine's odorous. That's a good first step. So thank you for that.
Sometimes the expectations from the caregivers are to prescribe antibiotics, so it's really hard not to do it. So we need to really do patient-centered case and Of course, knowing the evidence, we try to not to prescribe, but yeah.
We do have a patient in with a sepsis syndrome, and there is a positive, likely a positive urine culture. It's not grown out yet. We have had patients that have been in for C. diff treatment, and so very commonly that's antibiotic prescription for urinary tract infection. Other thoughts from folks in the IMC group? You've been on call. You've received questions about this. Sometimes the education is not very helpful when the call comes in at 10 p.m. And so there's probably more things to do before in terms of prep. Any thoughts?
I think that's why I like the hydration protocol, because I'm not telling them to do nothing. I think doing nothing is going to be not met with, that's not going to be well received. So there's a protocol of something, for better or worse, by the way. At 10 p.m. I also can't get antibiotics. So then we're talking about what can we do, and many times it is addressing some other potential issues. Saturday night at 10 p.m. is challenging because I can't get a culture done tomorrow.
Yeah, home test. Thanks for that. And Katina is responding back with this home test strip. It's like, I have it in my hand. Here it is, it's purple. And going back to the caregiver author that we were talking about just a second ago, she was right about her mother did not have dementia, but everybody was seeing the delirium and assuming and writing and talking about that her father had, her mother had dementia. And it's like, it's not dementia, it's delirium. And so sometimes the caregivers are really right and astute in these mild changes, and may not be willing to do something different, but there's I'm not sure that it works, and there are some side effects, and so important to gather as much information as possible. Hey, I wanted to go back to this sign out sheet. Thanks so much for joining us, and if you had comments or questions or wanted to provide a review, really appreciate that, and you get CME credit for joining. Dr. Cohen, back to you.
Thank you so much, Ted. It was a very interesting talk. Thank you everyone for attending, and we see you again next month in January. We're going to continue with this cycle of educations on dementia and Alzheimer's disease related dementia. And we do have another question in the chat just before we say bye. It's gone. So Kathy Lyles is saying that she had referred patients to Dispatch Health mobile urgent care that will collect the urine sample and can prescribe antibiotics the same day. That's very, very useful. Thank you so much, Kathy. Okay,
Katie, I like about that suggestion that there's likely helpful instruction and assistance in collecting the urine sample, which I wonder about whether or not the caregivers can do. Hey, thanks everybody.
Bye, thank you.